As a part of the response to COVID-19, Seniorcare participants were allowed to purchase 100-day supplies for certain prescription medications instead of the normal 34-day supply that was previously allowed. These changes were only temporary and they expired in December of 2022. If enacted, this bill will greatly benefit seniors by reducing the number of trips to the pharmacy, especially those in rural Wisconsin who often have to travel great distances to reach a pharmacy. Additionally, this bill provides significant savings for all senior care participants at the same time as reducing the overall cost to the state. The Senior Care program was created over 20 years ago by the 2001 through 2003 biennial budget to provide prescription drug assistance to Wisconsin residents age 65 and older with incomes at or below 200% of the federal poverty level. The program operates with approval from the U.S. Centers for Medicare and Medicaid Services, the CMS, and it's available in Wisconsin through a Section 1115 Research and Demonstration Program waiver. The program was first approved by CMS as a 5-year demonstration project in July 2002, and it most recently received approval from CMS in April of 2019 to operate for another 10 years, so through December the 31st, 2028. Senior care captures our elderly population that have too high of an income to qualify for the normal Medicaid program, yet too low of an income to adequately afford purchasing their medications. As of April 2023, there were 1,709 people enrolled in senior care. Senior care enrollment is up 110,000, I'm rounding, in April 2022, 104,000 in April 2021, 96,000 in April 2020, and 94,000 in April 2019. So it's just continued to go up as the years have rolled by. Under current law, after paying an annual $30 enrollment fee, the senior care members incur copays of $5 for generic drugs and $15 for brand name drugs. Enrollees with incomes at or below 160% of the federal poverty level pay no other out-of-pocket cost, while those who fall into one of the 3 higher income range categories, they have to meet certain spin-down or deductible requirements. The individuals enrolled in senior care currently pay $15 copay for 3 34-day supplies of the generic drugs. And under this bill, they would only pay 1 copay for $5 for that 100-day supply. Brand name drugs currently require a copay of $45, so it's $15 for each of the 34-day prescriptions, but if we did it into 100 days, then they would be able to only pay 1 copay of that $15 for a 100-day supply. So the copays, we need to understand, are a revenue to the Medicaid program. Under current law, there are 390 drug products that are on the 100-day supply list. And these drugs are detailed, and I can read them off if you want to hear them, but I put where they're detailed in the DHS publication. And this listing represents 22% of current claim volume for the Medicaid and senior care combined. So senior care copayment revenues for these drugs total an estimated $1 million of all funds. With this bill, the DHS projects that the current 100-day supply list would double to 780 products, or 44% of the claims, with copayment revenues of $2.1 million. However, as the prescription would be filled only once every 100 days versus every 34 days, there's going to be a loss of these copay revenues, which we have to factor in. So with the anticipated doubling effect of this 100-day supply, the Medicaid program would lose a projected $2.1 million in Medicaid copayment revenues. However, the savings to the Medicaid program will still outweigh the lost revenue, and this is why. Prescription drug costs charged to Medicaid include what's known as a professional dispensing fee and the ingredient cost. The dispensing fee is $10.11 per prescription, for prescription drugs with an annual volume of over 35,000 and $15.69 for drugs with a volume under 35,000. The dispensing fee is usually paid once per member, per service, per month, per provider, depending on the prescriber's prescription. So in the calendar year 2019, for which the most recent data is available, professional dispensing fees for senior care members totaled $13.6 million of all funds, while total drug co-pays totaled $7.1 million for the same period. So in other words, the cost of this dispensing fee exceeded the revenues that we were getting in with the co-pays for the same medications, and the same amount of medication, same time frame. So using this data and projecting the same proportions forward, the projected savings for the total senior care program would be $1.9 million. And that's savings to the state. It's what the state's paying in Medicaid. If this bill is enacted and the waiver is approved by the CMS, it's a win-win. So we help our seniors, and then we reduce our costs. Another potential cost savings of this bill is in direct health care costs. Patient non-adherence to prescribed medications is associated with poor therapeutic outcomes and progression of disease, which increases direct health care costs. If a patient has a 100-day supply of medication, they're more likely to take it until the prescription runs out. At a 34-day supply, a patient may decide to not refill the prescription for a variety of reasons. Having a 100-day supply lends more assurance that the person will take all of the prescribed medication. A meta-analysis that combined the results of 79 individual studies conducted in the U.S. and other countries assessed the cost of medication non-adherence across 14 disease groups. It was found that the annual adjusted disease-specific economic cost of non-adherence per person, so they're not taking their medication, it's resulting in worse outcomes for them. It costs directly, medical costs, $949 to $44,190 per patient. This bill does require the Department of Health Services to seek a waiver from the federal government to once again allow senior care participants to purchase 100-day supplies for certain prescription drugs. If the waiver is approved, the existing DHS administrative rule would be amended to allow this change to be implemented. Some medications would still require monthly renewal. That's based on clinical considerations to safety and costs.